So I think we can start, Dr. Devin. Okay, wonderful. We'll wait for the others to join us later. And I would like to welcome you, Dr. Devin, and thank you so much for accepting the invitation to give us this amazing talk. So, brief, Dr. Devin is one of the Canada's first physicians to specialize in clinical artificial intelligence. He's an emergency physician at the Hospital of Sick Children, Sick Kids, and holds a Master in Computer Science degree from the University of Toronto. He's an assistant professor at the University of Toronto in both of the Metri Faculty of Medicine and the Division of Computer Science, and is an emerging scholar helping to innovate the regulatory, privacy, and ethical landscape for AI in Canada and beyond. And he's also a co-founder and CEO Hero AI, a healthcare tech company dedicated to empowering patients and provide us with AI. He will take us through AI in pediatric emergency medicine. What should we build? What should we trust? And what should we avoid? So, Dr. Devon, the floor is yours.
Amazing. Thanks so much for the invite and having me. And I hope everyone is doing well and is keeping safe. And I hope everyone enjoys this presentation. And so, what I was hoping to do was just to dive into a bit about my journey around clinical artificial intelligence in pediatric emergency medicine. I mean, if you have questions, feel free to ask along the way. We can keep this pretty informal and more discussion based. I'm just going to launch into it and let's just see how it goes. So I'll get my slides going. And I'm assuming that you can see that okay, and I'll just get it full screen in one moment. All right, and I'm just going to get my iPad connected. Perfect. Okay, you guys can see that okay? I'm going to take no response as a yes. So hopefully everything is good.
Yes, it's
And Perfect. Thanks for the great introduction. And so, I'd say that my journey into clinical artificial intelligence and probably like most of your interest is really piqued by some of the challenges that we're facing in healthcare. And so for me, it was really around some of these like, tough patient cases that I experienced along the way. And before I dive into things, just as a disclosure, I am a co-founder and CEO of a company called Hero AI. There are a few ways that we apply our technology in the emergency department at Sick Kids that uses Hero AI, and so I'll be really just like clear and explicit on what is Hero AI, so that that conflict is clear to everyone in the presentation. And so for me, when I think it was about like an R2, like my second year of residency training at Sick Kids, I was part of the Code Blue team. And I remember this was like the first week I'd started, and the pager going off, running into the emergency department, which was kind of weird because normally a code blue wouldn't go off in our emerge. But someone had hit the button, and I remember running down, and the code team leader pointing to me, pointing to a bed, and you knew exactly what to do. Like I was the junior member of the team, jumped up onto that bed. There was a nurse on the other side, and we started doing CPR on this little kid. And I remember this really sad, like just tragic feeling of this young patient slipping away beneath my hands. And at first, I thought, I guess this is something I'm gonna have to get used to. I want to do pediatric emergency medicine. This is part of that. And that was my like initial takeaway when I walked out of that room after that patient had died. Because I just didn't know any better, and I was so junior in my role at the time. And then you go into like the serious safety event review, and you hear the presentation, and you start to realize that this patient like walked into the emergency department, and this little boy had an illness that if we'd got to him faster, he'd be alive today. And that really, really shook me and it really upset me. And you just start to think, like, Sick Kids right now is the number one pediatric hospital in the world, according to whatever US rankings magazine posts that. And at the time was still like a top ranked hospital. And you just start to get upset by that and angry about that. And I started to look into this more, and you realize that now more than ever, but even at that time, we're facing an increasing challenge around wait times, resources, particularly across North America, the UK. Maybe you experiencing this in Saudi as well. But we do know that every hour where someone is waiting excessively long in an inappropriate way, it just leads to worse outcomes. And that's what happened in this case. This boy wasn't obviously unwell, but there were bits of data captured in his electronic health record system that would have said that like he wasn't the kid who shouldn't have waited, even though he looked great. His vitals were normal. He walked in. There were clues that he shouldn't have been the one to wait, and that really, really upset me. And so I started to dive into this, and you start to look across all of these different health systems, whether it's in Canada, the US, the UK, Australia, all around the world, was discovering that we're facing this really difficult challenge. And this was back then. Now magnify that to now, and it's just an even bigger issue. Um, and I started to try and find solutions. I initially thought that maybe, and again, like many of you will know this, you can kind of be like naive when you're a junior physician. And so I thought maybe we'll all just go faster and we'll just work harder and somehow that'll just work. Obviously, we can't go faster. It's like really difficult to do that. And so, but I didn't know that at the time. And I started learning a bits about like quality improvement methodologies, PDSA cycles, and joined the flow committee and just found that like despite the effort, we actually couldn't go so fast. And even if we tried to go faster, um, you risked compromising the quality of care potentially that you were giving. And so that was interesting. I also then started to dabble in a bit of patient advocacy and patient literacy, thinking about, well, what if we got like the right health literacy information to the right patient at the right time? Would they maybe come to hospital earlier? And maybe could these really difficult outcomes be prevented? And that was really interesting. And there's probably a lot of truth to that, but I just didn't see how that could scale to solve the problem in the way, for this particular case, in the way that I wanted it to. And I quite literally, like, accidentally stumbled across artificial intelligence about 8 to 10 years ago now. And all of a sudden, these light bulbs started going off. I started to realize that AI could help us connect the dots between a lot of the different challenges that happened in this case. And, at the time, we were just rolling out our electronic health record system, or the EHR. And I started to realize that AI could help us navigate this big data maze that was being generated. Like we were generating so much information about every patient. It's almost like too much as a human to digest. But AI could help us navigate that, which was really interesting to me. And I started to realize that AI could solve some of the failure points in this journey for this patient in a way that no other technology or intervention could solve. And so I'm going to, throughout this presentation, show you a few different projects, some that are related to being more proactive, as you see on this slide, and thinking about emergency operations and sort of logistics. And then some that are also very like precision medicine based in a sense, like very much around targeting like how do we improve on the patient level care for individual patients. And I'll show you how we're deploying that. And I'm really excited to dive into this. And so on this slide here, what we're looking at is really around us at typically in Emerge, we are very much reactive to the situation. And we're really good at being reactive to the situation, but sometimes that's not the most helpful thing. And so this dotted line here, the red one, is the line where we probably should be opening up overflow areas. And honestly, it probably should be over more to the left. But that just represents like this is the last, like sort of the latest moment where you should be opening up an overflow area. This like these blue sort of greenish spikes here, they represent when we actually did open up the overflow area and when patients actually started flowing through. So we were just looking at this in our electronic health record system, and we realized that we were missing this window of like 2 to 4, sometimes 6 hours where we weren't fast enough to open up new care areas, which meant that like patients were having bottlenecks in their flow to being seen, even though we probably had physicians that could see these patients, they just weren't being put into rooms. They'd sit in the waiting room, or they would sit in like the cafeteria sometimes because their waiting room was full. And so what we realized was, well, could we do something about this? Like, could we predict when we should open up an overflow area and actually get it open before the surge of patients arrives? And so we built this machine learning model that looked at predicting census, which, as you know, is like the total number of patients in the emergency department. And we just wanted to understand like when were we gonna simply run out of rooms or not? And the first wave of how we rolled this out, and we still use this, but the first wave of how we rolled this out was combining analytics and AI to give a bit of insight. And so here, for example, this might have been the census in our emergency department, over the last 12 hours or so. And then here's what the predicted census was going to be. In order to train this machine learning algorithm, it's looking at like so many different features. It's looking at like our historical trends or volumes. It's looking at provider efficiency. It's looking at the weather. It's looking at the time of day. And it's making a prediction every hour for the next 24 hours what the emergency department census is going to be with a bit of an error bar there. And so we deployed this and we put this into our dashboard. We have this nice dashboard that the charge nurses and the admin on calls would look at. And so we embedded this into this dashboard. And you know what? It didn't really do anything. The prediction worked really well, and what's super cool about this model is that it would retrain every day because census and patient trends can be really dynamic. It would retrain itself every day. It picked the best version of itself and self-deploy. It's totally autonomous in its own governance. And uh, really, really cool model, but nothing was really happening. And what we started to realize is that, like, in the emergency department on the ground, like, if you're on the front line and if you're like that charge nurse or that admin on call, yes, looking at dashboards, it looks cool and it's like interesting data, but you just need the dots to be connected, especially when things are getting really busy. You don't want to be sitting and wasting your time looking at dashboard. You just need to know what are you supposed to do. And so through just like design methodologies and stakeholder engagement, we realized that at 10 a.m. was this ideal time for our charge nurses to gain a prediction that would basically tell them they're going to have to open this surge area or this overflow area early. And if we delivered that prediction at 10 a.m., it gave our charge nurses enough time to rethink the nursing schedule and like the human part of the logistics. Because you can't just open an area. You need to make sure like the area is clean. You need to like, take it over from like the orthopedics team. You need to make sure there's like nurses who can get over there and to be able to provide the care. And you've got to figure out like what doctor are you going to float over to this overflow area, right? And so having that prediction at 10 a.m. was like the key time. And so rather than showing people this graph here, which I think looks really cool and beautiful, and it's nice how it connects and it flows, it wasn't helpful. What we just needed to tell someone was like, yes or no, every morning at 10 a.m., are you going to need the overflow area? And they just plan for that. We need this area. When you look at the past data, we have to open it early about 35 to 40% of the time. So it's not just that we should open it all the time, because if we did, it actually slows down providing care for some of the more acute patients. And so we needed to use it in a bit more of a precision way. And so at 10 a.m. every day, our charge nurse in particular, will get a prediction. And it's just going to tell them, like, you need to open the area or not. They do a little huddle, they think through their resources, they plan to open that care area early. And what we're effectively doing is before that surge of patients arrive, we're prepared and we're sitting and waiting for them. And we've actively deployed this and we're measuring results. And the early results are showing that it is reducing wait times because we're not just leaving patients in the waiting room, but it's still pretty early days. And so we'll have to see how the overarching results look in about a year from now. One of the really cool things, though, and I alluded to this, is that we've built this model to govern itself. And so part of that is that we've got like sophisticated real-time dashboards. And when you think about like from a responsible AI perspective, it's one thing to validate the tool, and to know that like it's safe, it's equitable, it's going to work as expected, like doing that sort of retrospectively and prospectively in your silent trials. But when you deploy these solutions, like the job's not done. You actually like need to monitor the tools forever. Like when you deploy them, they need to be reviewed like forever. It's quite a lot of work. And all of the emerging international standards will say that these tools need ongoing monitoring. What we've done is we've built like a monitoring system that will just automate that process. And so we're generating these metrics in real time. We've set like thresholds where if the tool is deviating from expected performance, it will flag a human to review. And the reason why we've built it that way is because we're just anticipating that at like a massive scale, how are we going to have all these humans monitoring all these AI tools? We actually need the AI tools to have some form of like self-governance or automated like technology monitoring them. And so that's what we've built. One of the cool things that we've also done though is we've started to add as a metric, not just like the precision or the performance of the tool, or looking at like the workflow impact. So, for example, are we actually reducing wait times for patients? Are we actually opening up the care areas earlier? If you think about like a PDSA cycle and the quality improvement metrics, are your process measures being monitored? Are your outcome metrics being monitored? Are your counterbalancing measures, like, are we inadvertently causing harm potentially by seeing these kids faster, right? Like, you shouldn't, but like maybe you might. And so we're monitoring all of those things. But we've actually added environmental impact to our monitoring board. So for all the tools we deploy, we're measuring the carbon footprint that gets generated just through the retraining protocols, through hosting the algorithms, and we're looking to see like how like what kind of carbon footprint is each tool actually sort of generating or causing. Honestly, I don't know. Like, what is too much carbon footprint versus what is okay? I don't know. And I don't know that there's like any straight answer out there for that. But what we decided as a group was, well, if we don't start monitoring it and sort of measuring these things as a metric, we can't even begin to have the conversation to spark this debate of like what is too much versus not enough. And so we're monitoring it, and we're hoping through collaborations, possibly with folks in Saudi and around the world, we can understand like how to interpret this. So to me, that stuff's really cool. It's a really interesting engineering task from an AI and computer science perspective. But the real area that I love to do work in is when it's like immediately patient facing rather than just like hospital logistics. And so this here, like, let's just, take this little boy. He's about 6 or 7, and he's at home having tummy pain. He should be out hanging out with his buddies, having a good time, but he's got some tummy pain. And his mom needs to decide what she's going to do. She's going to bring him into the emergency department. And so, if you look at the traditional workflow in an emerge, the patient would arrive, a triage nurse would capture like the triage data, vital signs, some free text information about why they're here, some past history stuff, demographic details, and they are put into the EHR. And typically, a patient, and imagine this is like a really busy like day in flu season. Typically, a patient will sit and they might wait if they're not like critically unwell looking, maybe 2 to 4 hours. Some of you have trained in our emergency department and have had the pleasure or displeasure of being in our emergency department in the sort of dead of winter when it's super cold, when we're like in the heat of flu season, and it's really busy, and that our wait times can exceed well over like 6 plus hours, 8 plus hours sometimes. And so, but typically, like let's say 2 to 4. And this patient's in the waiting room, goes into assessment room, sees like a super talented resident, like some of you, or like a staff physician. And we say, yeah, you know what? You've got tummy pain. We think it could be appendicitis, and we order an abdominal ultrasound. But then you need to get that ultrasound completed and resulted. Maybe that's another 2 plus hours. And by the time you're going through this whole journey, if it's really busy, like you're getting to like 8, 10 hours. until you get a diagnosis. And by then, you're in the middle of the night, and it's like much harder to do that surgical procedure. And if you think about the stakeholders in here, you've got your ultrasound techs, you've got general surgery, you've got the actual OR and ensuring the OR is available, and we've got to figure out like, are we going to have a nurse available to see that kid after the operation? And are we going to have the appropriate bed spaces? The thing is, like, this kid is going to take up a bed space because they have a surgical problem, but the issue is it like ripples back down into another bed not necessarily being free, and an emerged patient sitting in RED overnight waiting for a bed space to be free, which is often not a physical problem. It's like a lack of nursing resource problem. And so we thought to ourselves, like, could we use this data and just predict that the patient would have appendicitis? And if we could predict that they had appendicitis, could we just like automate ordering the test even before they've seen the emergency doctor? I think about that. What I'm basically saying is, can we give the medical legal authority and like the medical directive to an AI system to provision care for a child without a human in the loop besides the family? Sounds a little drastic, sounds a little bit crazy, but it makes a lot of sense, right? Like just like how we use nursing medical directives, if we could get the testing to be completed during this time while the patient was waiting, we could at very least like start to add efficiency here. And if you could do it really, really well, imagine a world where that data is coming from a patient's home, and we see that the kid is safe, and they maybe go straight to ultrasound even before entering the emerge. And so, if we could build a model that was able to work on this type of triage data, we felt that like it could be really powerful to advancing care one day. And I'll tell you right now, that really sad story at the top of this talk, that really is driving a lot of the work I do. And I almost get a little bit emotional thinking about it because it's such a strong experience for me. If we had a model that worked like this, that kid would be alive today. And so this is a big part of why I'm focused on this space and thinking about AI, and I'm working on triage data. And so what we did was we tried all these different AI techniques. We took all the triage data, fed them into a variety of models, and we saw that we were able to predict if a kid has appendicitis and potentially order an abdominal ultrasound. What you're looking at here is something called an area under the receiver operator curve, or an AUROC. If you look at different research studies for decision tools and whatnot, you'll come across this. So this isn't like a computer science thing. It's just like an outcome metric for evaluating some sort of classification tool or sort of decision tool. And what the plot shows is a true positive rate on this axis here and the false positive rate here. And so everything in AI, there's a trade-off. And so a true positive rate means that if we said we want to capture 100% of the kids who have appendicitis, okay? So we want to try to have an AI model that's going to detect 100% of all the kids who have appendicitis. We have to sit up here in the curve. And so if you sort of go over, you'll see once you intersect with the actual green line here, which is the performance of the machine learning model, so it sits about here, you'll see that in order to achieve 100% true positive rate, we're going to have a false positive rate of 40%. So what does that mean? That means that if all the patients who come through the emergency department are false positive rate, like 40% of those kids we're going to send to ultrasound in an automated way. Now just like think of what radiology would do if we actually did that. It's not going to go down very well. And they're going to come after me and get really upset. And so obviously we can't do that. So very quickly, although this curve looks near perfection, because perfect would look like this. So this is a great curve and great outcome metric for writing a publication and like having a really great manuscript. And we did that. We published this in one of the JAMA journals. Um, But when you think about operationalizing this tool, and thinking of it on like an individual level and on a workflow level, you get humbled really quickly, and you start to realize that you can't automate these ultrasounds for 100% of these kids, because in no way is radiology going to allow you to send 40% of your population to their ultrasound machines inappropriately? And so what we did was we thought, well, okay, look, well, what if we had the model working here where this star is? What if we captured 20% of these patients and we automated care for 20% of all the appendicitis cases? And honestly, like you can maybe even edge this up to like close to 40% of all of these appendicitis cases. Well, if you look like the false positive rate, it's not actually zero, but it's really, really low. Like it's 0.0008 at where we set this threshold. And so what that means is that like when the model says that the kid has appendicitis, there's almost never a false positive. It's almost always true. Just get the ultrasound done. But if the model says that you don't have appendicitis, well, you're gonna miss, you're missing like 40, 60% of the kids, right? And so in that scenario, um, let's not send the kid home. Why don't they just go down the normal sort of pathway? And we started to realize that like although that wasn't as like didn't sound ambitious, like, oh, you're only going to get 20% of those patients, but it starts to add up because when you start to apply this same technique to things like testicular ultrasounds, x-rays for fractures, ECGs, urine testing, what we discovered in our emergency department was at this super humble threshold of getting 20% here, 40% here, 40% here, you could start to actually automate aspects of testing for just under 25% of all the kids coming through your emergency department, which ended up being really powerful. And so we started to realize that we needed to take a high precision approach if we were going to play in this world of automation and have workflows that would like accommodate that. Like if the model didn't fire positive, it's okay. They're going to go down the normal journey. But if it does fire positive, let's accelerate care forward. And so I'm really excited because this like automation pathway this year, we've been testing it behind the scenes. So it's right now, as we're talking live, patients are getting these predictions. We're just not exposing the predictions to anyone just yet. We've been doing this for over a year and a half now. You're some of the first people to see the results of our silent trial data here because we haven't really presented this yet, haven't published this yet. And we are going, the models are working great, just as expected. So we're going to be turning these on live this summer as part of a clinical trial, which is really exciting. But one of the challenges is thinking about how do we actually get AI into the hands of clinicians and patients. And it was actually years ago where I got the first set of results, probably it was like 5 to 6 years ago, where I first got the initial retrospective results for this tool, and I could see that this was going to work really well. But if this was truly to be autonomous, like no physician in the loop, the AI tool needed to somehow be in the hands of the patient in this particular use case. The AI tool needed to interact with that family. And so, in parallel, I very quickly realized that the work I was doing, I could have some really cool publications, but honestly, like, don't say this to anyone, but like, because most of my portfolio is AI research, but I don't really care about the research in a sense. Like, I don't care about the publications. I just wanted to uh, improve care for real. I wanted these tools to be translated to the bedside. I wanted to prevent that case from ever happening again. And so for me, I started to get a little distressed about like there was no technology platform to host these models in real time. There was no like super adaptable, configurable like sets of interfaces to facilitate a prediction to patients and families. And that's where Hero AI comes into play. And this is the health tech startup that I created in partnership with Sick Kids while I was doing this research to really figure out solving that problem. And so what's really cool is right now, in our emergency department, we've created our patient-facing application. This thing here is called Beacon Bear. Our Sick Kids comms team came up with this like beautiful visual. And what patients can do when they come into our emerge is they can tap their phone on a poster using like RFID and NFC chips that are secured and locked down, and they jump into a patient-facing application. This is just like a fun Gen AI video. Obviously, glitter doesn't like shoot out of the posters. It probably create a big mess. But the idea is that like parents can just like and their kids can walk up, tap the Beacon Bear, and they end up landing into this patient-facing application. And, if you say to a family, and we surveyed a bunch of people, and what we realized was if you say to a family, hey, you may or may not get a prediction about automating test ordering, um, that's not necessarily like enough to get someone to like take their phone out, tap onto a poster, and like register into this application and start using it. But what do families actually want, and what drives anxiety in an emergency department from a family perspective? It's when they're sitting and waiting. And it's when they have no idea what's going on as they're just sitting there waiting. And so this like feeling, especially if it's a bad day where like people are waiting a long time, this feeling of like, have I been skipped over? Am I getting closer to being seen? Have people forgotten about me? Can I get up and go to the washroom? And if I do, are they going to call my name while I'm in the washroom? Like these are literally all responses that we sort of gathered from patients who we surveyed while they were waiting. And they basically said to us, there's very simple things that they want to know. They want to know their position in queue. They want to know what their anticipated wait time is going to be. They want to know how busy the emergency department is. And so we've created through this patient-facing application an individual, like personalized dashboard that shows patients all of this information. It updates in near real time. They get to sort of see what's going on, and they feel connected to us, and they start to feel like progression is happening. It's kind of like if you order food from a delivery service, and in the early days, with like Uber Eats in particular, what would happen is you'd order your food and you just sit there waiting, and like the app wouldn't show you anything necessarily, and you like hope your food was coming. What they discovered was what they needed to do was actually show that little car or that little person on the bike getting closer and closer to you. What that did was reduce a whole bunch of their clients like reaching out, messaging in, being like, "Where's my food? Is it coming? Like, do I need to order again? What's happening?" Right? Having that situational awareness, that like progression, even though you're just sitting still waiting, having that oversight and that insight as like a client and then also as a patient really reduces anxiety. And so this was like the nugget that we needed to give families in order to land into our patient-facing application, which is like this digital ecosystem. But then like the brilliant part about it is we also created this inbox. And so in a totally automated way, based off of patients' data, we could start to deliver messages, predictions, or maybe deliver some sort of interface about, hey, we want to order an ultrasound. Do you consent or not? And so, really, we saw this as empowering patient autonomy directly by taking the electronic health record information, thinking about like running it through algorithms through our real-time platform to predict, are you going to need an abdominal ultrasound? Having that prediction interact with the patient and family directly. How to do this well is still an open research question. It is not out there in the literature. We have to think through that as we work towards fully automating this pathway. But what we are going to do initially is have a physician assistant facilitate the actual order placing, while in parallel, we do research on understanding how do you ethically and responsibly and in an equitable way interface with these patients and families. But what we hope to do is then be able to automate placing that ultrasound order. The anatomy of this platform is really interesting. Effectively, we have this ability to take any type of electronic health record system data, process it through a whole collection of algorithms, and display information through like sort of websites or web apps that are provider-facing mobile app and patient-facing app. And we're looking to partner with some sites to actually start to deploy autonomous robotics, where just like the AI system might say, hey, order this ultrasound and send a message and an alert to a patient or a provider, even. We also have this ability to use very basic data processing and AI to trigger an autonomous robot to say, hey, move the patient into X-ray, or move the patient out of a care room, or get them from A to B. And so we think that's going to be another interesting sort of study to work on. And it's going to be driven by our platform here. And effectively, if I stepped back and I thought about that case, um, and I just thought you just think about like there was a signal in the data, like there was stuff in that triage note that basically would have clued into us that this kid shouldn't have waited, I started to realize that healthcare is going through this like massive digitization effort. We're all rolling on electronic health records. You're a bit more advanced than we are in Canada in the sense that like a lot of sites in Canada still aren't electronic health record based, but they're all dialing on like now. And we're going through this effort of creating these digital data, but we still have humans needing to look at the data to drive real world impact. Every other industry, like regardless of what it is, uses their active digitization. The whole point of why they're going digital is because they are automating something, right? Like, or else it doesn't really make sense. Like, I mean, I get there's a lot of value to being having a digital health record, so I'm being a bit dramatic here. But like most industries, the value proposition to them in having an electronic system is so that like stuff just happens in an automated way. And we don't do that yet. Like we have these electronic health record systems, but we're not driving to that real world clinical impact. And so we think that healthcare is missing that automation layer. And this is the space that I'm trying to focus my AI research in is, having platforms like Hero AI and having like the research work that SickKids is doing sit in this automation space to solve that part of the problem. And we're already starting to see real world impact. And so through this platform, we're ingesting all of this real time patient data, and we have this ability to look through everyone who's waiting in the waiting room, run them through algorithms. And this is a model that effectively is predicting like, is a patient meeting the criteria for psychiatry consultation and intervention? We see a lot of kids in mental health crisis in our emergency department. And this model is predicting that, detecting that, hey, this kid's eventually going to need psychiatry, and in a totally autonomous way, reaches out to psychiatry, consults them, presents the information, and the psychiatry team just comes and sees the patient well before I've seen them as an emergency physician. So this is not provider in the loop. This is a total autonomously acting tool. And what that's done is it's reduced the time from when patients arrive to psychiatry intervention by 55%. It's reduced the length of, the wait time by 60 to 90 minutes per patient. And most importantly, it's reduced our length of stay of where that patient is sitting, using up like a room in our emergency department by on average 60 to 120 minutes per patient. That's added up to like over 1,000 extra sort of room hours per year, which is really, really powerful. And all it is just like adding a small block of automation to expand my capacity as an emergency physician. That when I'm working on the patient here who maybe has sepsis or has some sort of trauma or MVC, I have this reassurance of that kid who is presenting in an acute mental health crisis, which is such a sad thing to like see, and they're in such a vulnerable state. I know that their care is moving forward, totally autonomous, without me having to get involved. And I know that like me focusing here isn't going to hold up their care. And that's it's really cool to see the power of the small little blocks of automation. Um, one of the big things though is that it's not the AI or like the technology that drives change still, right? Like even though yes, the tool is sort of skipping over me as the emerge doc and it's bringing psychiatry down faster, but it's actually humans still ultimately for now that are providing the care. And so um, QI methodology, PDSA cycles, things that our hospitals are really good at doing. These are like methodology, design methodology as well. These are all like tools and frameworks that are key to translating AI technologies to drive impact, right? And so what we discovered was we needed dashboards that like, where, people didn't understand these like cool little abstract figures. And so they needed like the AI system to talk to them through a dashboard. They needed to receive the alerts through a mobile app that showed a very specific type of formatted data. They all needed to get an Apple Watch alert because they all had Apple Watches and that's how they wanted to be alerted. And I know it sounds silly, but it's like these little things that come from just doing cyclical PDSA cycles really quickly and iteratively is what drove the success of this workflow and it drove the adoption. Um, this here is just like a bit of a zoom in to show that now what we've got on our dashboards that sort of just sit in like our command on the west side. Some of you have come and worked with us on the west side. It's kind of like the side that runs the emerge. You know, different colors will light up when patients are in different states, and we have models firing alerts to a mobile app, but also onto the dashboard there. And so to me, the automation is really powerful. I also think that AI can really help us add a bit more precision to our history, physical exams, and our diagnostic decision making. And so you'll start to see a bit of a trend here. I built my research program and my AI work just like focuses on patients and problems that just make me angry, apparently. It's kind of what I'm starting to realize, at least. And so here, I had these two patients. This was through the pandemic, actually. Little boy, 5-year old, and then one was a 17-year-old girl. And sadly, I ended up having to diagnose them with brain tumors. The part that like and you know you guys will have gone through similar things, right? It's always a hard thing to do to like disclose that diagnosis, but the part that like stuck out for me with these cases, even though before I had, delivered this really terrible news so many times before, these two moms yelled at me, and it wasn't like grief, it was rapes. Like they were borderline like I was gonna have to call security for one of them. And it really, again, it just like shook me a bit. And the reason why they were so upset was that they kept going to their regular doctor. Like they went and saw their family doctor, and then they asked for a consult to a pediatrician, and they're doing headache diaries, and they're trying Advil and Tylenol, rah, rah, rah. Like, and these kids looked okay. Like this girl was being told it was related to screen time. Because remember, during the pandemic, all these kids were doing like school via Zoom and stuff, right? This boy, his only symptom was he would be playing and then like in the backyard, and he would just like sit and stop and put his hand like this. That was it. He wasn't vomiting a whole bunch at night. He wasn't give me 1 second. I have another meeting popping up that I'm gonna be late to. It's all good. Don't tell them. Okay. And he wasn't like these weren't the obvious red flag kids. And so it was tricky, and admittedly, like you get it. You get why those community providers didn't just send them to a CT or an MRI. And so I started to dive into this and was, don't like fact check me on if was what the original version looked like. This is just what I found online. But if you look at how the technology started with doing fundoscopy and like checking for papilledema, and if you look at like what we use now, to me, these two things are the same. I get that there's like a candle here, but the concept of like trying to use some sort of magnifier tool of some kind to look through someone's pupil and like the pupil of a child, right, who has headache, who's in our emergency department, who's obviously not going to stay still, and we're going to look through this kid's pupil and we're going to check for papilledema. Like it's ridiculous, right? That we're going to ever be good at doing that. No matter how much training I get, I'm always going to be terrible at doing that. And so in our emergency department, we started using point of care ultrasound where kids could like close their eyes. You put a little eye patch on. We tell them, oh, we're going to put some cool blue slime on your eye, and we're going to get a cool picture of the back of your eye. And here, you could see this is what a normal eye would look like. This part here is like your lens and like the part of your eye that you could touch right here. And this is like the back of your eye where your retina is here. And where you're looking for papilledema is right in this circle right there. And so if there's like increased pressure in the brain causing papilledema, it will appear on these ultrasounds as a little bump. So I'm hoping you can appreciate that on the presentation, that this looks really smooth and that here there's a bump that's kind of protruding out. That represents raised optic disc elevation on ultrasound, which is like effectively like if you were using fundoscopy, it's papilledema. Much easier to appreciate on a point of care ultrasound, much easier to like capture this type of image, but it's still kind of tricky because you don't see that many positive cases. And if you take the technology and again using design methodologies, stakeholder engagement, understanding the root and the source of the problem, and just engaging with community providers, you start to realize that even though the act of capturing the images is actually pretty easy, you could teach someone in like half a day how to do this, even like a couple hours how to do it. To teach someone to be expert at knowing that this is true papilledema or raised optic disc elevation versus not, and to make you confident in that, like it actually takes a lot of experience and time. And the thing is, like any one individual community provider are maybe going to see a couple brain tumors in their practice, like throughout their career. It's not going to be as concentrated as we are in the emergency department. Like, unfortunately, like they all come to us, right? And so that's why we have this increased experience and we have all these positive cases in our data set. So we thought, like, what if we took the point of care ultrasound images and those sort of video sequences, plug them into a deep neural network model. It's just a machine learning algorithm, right? This is like the anatomy of the algorithm, the different layers and whatnot. Not important. The whole part is that we're taking images, we're feeding like thousands and thousands of examples, right? Hundreds of thousands of individual frames to a deep neural network model or machine learning algorithm. And we're asking it to do one of two things. Say, do you have papilledema? Yes or no. Very simple binary decision. Turns out the model works incredibly well, right? Really awesome true positive rate. Great true negative rate. And these thresholds we can dial and change, just like I showed you on the AURLC curve. So the important thing here is the model works really well. We also, through some bribery, got some of the fellows and staff who are expert at looking at these images to hand label like hundreds of thousands of like individual frames for them to basically click like where do you see the pathology, and then we compared it to where our AI tool saw the pathology, and you could see that the model was like really anchoring on to the point that's like relevant for this case clinically. That the model understood that like it didn't matter about this area, this stuff here. It really was all about the posterior retina, and the model learned that, which was really cool to see. And so, what we have envisioned is now, with the advent of point of care ultrasound being like in our pockets, right? Like not in those big bulky machines. They're so much more affordable now as well. What we're working on right now is embedding these tools into point of care ultrasound, like handheld devices, such that we can scale these out to community practices. The last thing I'll show, because I know we're going to run out of time and I want to save some time for questions, so I'll go a little bit quick, is we're starting to dabble in Gen AI, obviously, because it's like everything is Gen AI right now. This is not something I'm saying that we should do, but it's something that we we've just been exploring a little bit. And so I had a simulation like CBME rounds, which basically is like you're kind of getting evaluated and to see that like you're working properly. Um, and this is just me. I think the blood pressure, Dylan, has dropped to 56 over 39. What should I do?
With that drop in blood pressure, we need to be more aggressive. Let's go ahead with synchronized cardioversion. Start at zero point 0.5 to 1 joules per kilogram. Are you ready?
We're getting ready.
Okay, charging. Okay, everyone hands off. Shock.
And shock delivered. Let's check the rhythm. With the heart rate down to the 140s, it seems like we've successfully converted the rhythm. Monitor the baby closely. Keep an eye on the vital signs. And consider consulting pediatric cardiology for further management and follow-up. Great job, Devin.
Thanks for your help, Dylan.
Just give us a debrief real quick on how we did in this simulation.
All right, for our debrief using the POST framework. First, positives. Great job recognizing SVT quickly, establishing IV access, and attempting adenosine. For opportunities, next time we could consider earlier cardioversion, given the baby's condition. And finally, takeaways. Overall, solid performance under pressure, with clear communication and decisive actions. Keep honing those skills.
Thanks, buddy.
So, this is me like at night, basically thinking like, hey, I'm gonna be a little bit cheeky here and have some fun in this session. And took the protocol for that simulation training, fed it into that was just basic ChatGPT, and it worked incredibly well. Obviously, that's not valid. I would never suggest any of you do that. That would be a dangerous thing to do. But it is to plant a seed to say, like, guys, like we have this emerging technology. We need to figure out how to shepherd this in responsibly. We need to figure out how can these tools really help us. And I'll say one other thing, and would love to come back or have meetings with you guys. But a key part to how we were able to deploy these solutions is through governance. It's through something that we built called the Sick Kids AI service. And it's where we were able to think through this right here, which is, you know, the technology is increasingly becoming easy. The harder part is thinking through how do you create a runway that brings the right people together with the technology, that brings the AI policy and governance into play, that actually, like, it's one thing to write a policy at your institution, it's a whole other thing to think through the processes and the procedures that operationalize those policies. Like, how do you put the framework or the runway in place so that your health leaders have like a framework and a system and a process for saying yes to AI-based technologies? We were very quickly and increasingly easily building the AI solutions. The biggest roadblock we were running into at Sick Kids was like this lack of a runway. And so we built it. We built out this thing called Sky Service. It sounds like a cheap discount airline, but I promise you it's super premium. And it basically allows us to get these tools deployed now really, really quickly and effectively. And this would be something that I would encourage all of you to think about, is that the technology is awesome, but thinking through how do you do it responsibly, how do you do it ethically and with equity in mind, and how do you operationalize those tools? It's something that Sky has done really, really well, and I know that Sky Service would love to continue building relationships with hospitals like where you guys are. So I'll take a pause there and see if there's any questions. Sorry to run a bit over. Oh, yeah, I think you're on mute.
Thank you so much. I would really thank you so much for that insightful session with great ideas. You're reminding us about the AI thoughtfully and balancing it with our innovation and safety in pediatric care, and top and most importantly, putting it towards the real impact and real world. We have a lot of questions actually, but let's start with a couple of them. First of all, Dr. Sufyan, he's asking in the chat, in your model that predicts patient surge, why you picked specifically 10 a.m. to predict surge or need to open a surge area, or that was just an example?
Yeah, so no, so what it was is at 10 a.m., we're predicting if at like 2 to 4 p.m., we're going to need that overflow area. And the reason why at 10 a.m. was it was the time when our nurses plan their afternoon resources. And so if we
Mm.
could get the model to predict really well at that time, our nursing team would have the data needed to actually be able to shift things around and open the overflow area earlier. If we predicted too late, they couldn't actually implement the change. So
Okay,
totally
amazing.
human-centered design on that.
Yeah, perfect. Another question. He's complimenting about the amazing ideas, but where to start? What is the hanging fruit for an ED with no AI experience, in your opinion?
Yeah, I think it's such a good question because everything that I've just presented today, we had nothing like 6 years ago, right? And so, and I know 6 years sounds like a long time, but it took us that long because, like, remember, like nothing really existed, and so we were like inventing all of these processes and procedures before AI was like as big as it was. And so you could turn these things on from a foundation perspective really quickly. And so I would say the most important thing are two things: being able to have access to your data in a secure, privacy compliant way that fits into your local regulations is a big thing. That's a key foundation, obviously the lifeline of AI. And having like the policies and procedures in place to actually get approval to build models, to try them out, to bring them to the bedside. Those are the two biggest things that could be solved, and things that I would say to focus on.
Amazing. Actually, you have mentioned it in your slides that Sky Service that they will be happy to have us on board, especially we are from different countries like Oman, UAE, along with Saudi. I think we can reach them if you can share us with their contact numbers. That it will be really amazing. There's another question. Amazing work in predicting positive ultrasound from triage and expedite patient's journey. What were the challenges to get your radiology department on board? Yes, this is a so challenging thing. I imagine telling the radiologist I want an ultrasound for someone I didn't see yet, but AI predict he has an appendicitis. What were the challenges and how you guys
Okay,
overcome them?
okay, so here's like I feel like the evil genius part to all of this is what I'm going to tell you right now, from the Emerge perspective. And so I thought that it was going to be a huge challenge as well. But one, again, thinking about design methodologies, like bring those stakeholders right in from day one. So collaborators on this project were radiology from day one, like mentoring the project and the workflow. Two, like if you take a high precision approach, which means really low false positives, if you operationalize a tool like this, what's actually happening for radiology is rather than the patient waiting 6 hours and then the ultrasound order being placed into the evening, the patient's getting the ultrasound right away. It's allowing radiology to do more work during the daytime hours when they have more capacity and more resources, and when a tech is going to do it rather than the poor radiology resident at night. They loved that idea, right? And so it's really about like aligning incentives and workflows and how AI breaks through those silos and barriers. And the only way you discover that in the different projects that you come up with and problems you solve is from day one, be really collaborative. Like bring them on board and co-design those workflows together. Same thing with psychiatry. Can you imagine like when we call psychiatry historically, it's like, ugh, you can just tell that they're annoyed. But they came up with a process of this workflow. And again, it means that their consults are happening many, many hours earlier into the day. That's so much better for them. And they also have governed exactly how the AI system will work, and all the updates happen from them. And so it's all like stakeholder engagement design methodologies, and you find these like beautifully elegant solutions to what seems like complex problems.
Amazing. Last two questions. The first one, regarding the different models that you have built, have you externally validate them with Canada or outside? Also, how difficult is to retrain the model in different population? How large is the data set needed to train the model from scratch?
Yeah, so sort of answering the questions backwards. So depending on the problem that you're trying to solve, you might need like a really large data set, or you might actually even need a small data set. Like I've got some models that are related to predicting craniosynostosis in newborns using photos for it's like a plastic surgery prediction. And we got a really strong prediction even after just only having like 400 data examples, right? So you don't need necessarily millions and millions of data points, depending on how clear the signal is in the data. And by that, I mean, like, if a human could look at the data and really clearly be like, yeah, these are that, and this is this, then a model can do it really well. And you probably don't need too many examples. So that's one part. The part about external validation and multi-site validation, that's exactly the phase where we're trying to solve right now. And so some of you might have seen an announcement where Sky at SickKids or SickKids AI made a partnership with the NHS and 6 hospital sites, pediatric sites across the NHS. And really what we're thinking about is how to contemplate, like, remove all the governance and all like the nonsense barriers. They're not nonsense, they're important things, but like remove them and contemplate them ahead of time through partnership so that we can actually better do multi-site validation in both directions. Something would totally be interested in thinking through partnerships with folks in this meeting as well, if you're interested. And in doing so, then we could start to answer these initial questions of like, how easy is it to generalize some of these tools? And I'll say that like the stuff that Hero AI does is highly, highly generalizable, just the nature of the way that the AI system works. The stuff like the automated ultrasound prediction is definitely not going to be immediately generalizable. We're for sure going to need to retrain the model on local data each time as we try to scale that out. And the only way we're going to solve that, especially in pediatric emergency medicine, is we got to partner together and work together and figure those things out.
Nice one, and I can't agree more. Last but not least, many people have concerns regards we don't really know how these models work. For example, black box theory of AI. Does these models explain how they reach to the output, like diagnosis, recommendations, etc.? As you know, that there are some ultrasounds that they are implemented with artificial intelligence that they try direct the trainer in order to examine the patient properly in a proper positioning. So, what's your comment on this question?
Yeah, it's a really good question. And what we're talking about is like how important is explainability to validating a model, right? Like the explainability of a model. I mean, how important is it to us that we know how Tylenol works? We actually don't know properly, like the biochemical pathway of exactly how Tylenol works. Like we don't know that. None of you really care because we all give Tylenol or acetaminophen or paracetamol, depending on what it's called, to like every kid who comes in. And if they don't get better, then they're probably maybe more sick than we thought. And so it's not necessarily from my perspective about explainability as it is about the rigor of validating the tool before you use it, right? And
Yeah.
so it's about knowing like what is the true positive, the sensitivity, specificity as it relates to my population. What is the generalizability to the people that I'm going to use an AI tool on? Show me the equity assessment and the fairness assessment so I could see that it's going to be equitable for males versus females, for children of this age, that age, and that age, right? Um, to me, that's like the most important part is generating traditional evidence-based medicine type metrics to know that something is valid. And even when you know that it's valid, because it's AI and it's digital and you can automate so much stuff, is to actually deploy the tool and then monitor all that performance forever, right? And
Yeah.
so to me, that's the most important thing as it relates to knowing that something is safe and trustworthy and being really transparent to families and patients about what we know about a tool, how it works, and what we don't know about a tool, so that patients and families can make informed decisions about what AI they're going to use versus not use. To me, that's the important thing. But if you can get something to be really explainable, great. But I would never err on the side of explainability and sacrifice performance of a solution. I would always err on the side of a better performing solution, but having all of the transparency around it, around performance.
Amazing. I don't want actually to delay your meeting meeting. However, I have a last question from my side. What are the
Go for
biggest
it.
risks or blind spots of AI in pediatric emergency care that clinicians should actively avoid?
Really, really interesting question. The biggest blind spots. You know, I think that what's interesting to me is that there are tools that will emerge from the electronic health record system providers that aren't validated in our environments, right? They often come from an American hospital or site, and as we see these tools and through the procurement processes, you start to see that like there's no real strong method or rigor for helping me know that the solution is going to work for my patients. That's a blind spot, and people are buying those tools. And so to me, that's really interesting. The other blind spot that is a little bit more difficult is around digital scribes and ambient scribes. And you know, what is the hallucination rate of the scribe solution that you might be using or you're thinking of using? Like they don't tell you. They can't tell you what it is on your local population as well. And so again, it just represents a blind spot. Does it matter? Maybe, maybe not. But it's definitely something that we need to be attuned to. What as you're seeing like the work that we're doing with Hero AI, the work that we're doing with Sky, I want to see, unlike everything else, I want to see pediatric medicine and in particular pediatric emergency medicine be the leaders in this space, and the adult world can learn from us rather than the other way around.
Yeah.
And I think that we have this like unique ability in Peds Emerge just in the way we think about things and the responsibility and the ethics and we're the right specialty to shepherd this technology into the bedside and to set the bar. And we're doing that already right now, and it's going to be great.
Actually, in our hospitals, I'll give you some heads up. Some of our hospitals, they have an innovation and an AI departments, and they are working their best to get ideas in the real world. And I think with this, after this meeting, maybe many of us, they will reach out in order for them to establish a really great collaboration between Sky Service and their hospitals. I think it will be really a great initiative. And lastly, I would really thank you so much, Dr. Devin, for an insightful session, a great reminder for using an AI thoughtfully, a balancing innovation with safety in pediatric care, along with your amazing, really amazing ideas, amazing great work you have done through Hero AI, along with the sick kids, and hopefully we have a collaboration together in order to implement the AI in Saudi and other Gulf countries to help the pediatrics emergency, especially the pediatric to decrease the burden in our healthcare system. Thank you so much for sharing that ideas, and we're really thrilled and glad to have you. And let's have you on board again with us.
That sounds awesome. I'm always happy to present and come back. And I put my email in the chat, so please like do reach out anytime with any extra questions or if anyone wants to meet and just chat. Thanks again, everyone, and hopefully I see you all soon.
Say bye. Thank you.